Um, Hello, Dr. Swapnil.
Hello, Dr. Roop.
Yeah, hi. I'm
Hi.
not able to log into this ecosystem. They're asking me for my current password and a new password. I can't figure out.
Okay. Dr. Swapnil is here. He will help out. Sir wants to log in.
Sir, good afternoon, sir.
Good afternoon, Bola. So, Yogesh, you got the number for this?
Echo wants him to log in. Dr. Roop, can you say that again? What's the problem?
So, it asked me to log in with my password when they sent me a reset password link. And when I connected on that, it asked me for my original password and then the new password. I mean, forgot password makes no sense if you ask me. So,
No problem, sir. We'll figure it out, sir. No problem.
Can we have
okay.
some here? Right? We'll be running the
We
slides.
can.
Yeah, you can log me in.
Yes, welcome to all participants and welcome to speakers also. So this is our 13th webinar, which is on the update on epidemiology and diagnosis of epilepsy and public health perspective as well and clinical perspective as well. We are going to cover in this. So first of all, I will just welcome to our honorary speaker. First speaker is Dr. Rup Gur Sahani, who is MD, DM, and FAAN who is consultant neurologist from PD Hinduja Hospital, Mumbai. Uh, Everybody will be knowing about sir mostly because he is working about around 30 years in this field. So he is board of director of International Neuropalliative Care Society. He's course director of International Neuropalliative Care Certificate course. He's also trustee for Forum for Indian Neurology Education. Similarly, he's a member of steering committee as well for ILLICIT, which is end of life care in India. And his major interest is in epilepsy as well as neuropalliative care. So, sir, welcome to our session of this current webinar. And similarly, I'm just introducing you our second speaker, who is with me, Dr. Yogesh Kalkonde, sir, who is also neurologist, and he has almost 20 years experience in his career till now. The specialty of sir is he has studied in US for neurology, MD neurology, and he joined the organization which is working in the remote area in Chhattisgarh, so which is known as Sangwari. So he's working as a public health practitioner as well as he's working as a neurologist. So, sir, welcome to our session again. Because he was in the previous session also he joined us for this update on the snake bites. So this is second session which sir is going to cover with us today. And see, sir has almost many publications in national international journals as well. So sir, welcome again. And just wanted to invite Ambedkar sir also, who is going to come for the addressing. Sorry. Just 1 minute. This sir is joining. So our agenda is today. First is the epidemiology and clinical management of the epilepsy, and second is diagnosis of epilepsy. These two sessions will be there, which we are going to cover. So first session is diagnosis of epilepsy, which will be taken by Dr. Gursani sir, and second session will be epidemiology and clinical management of epilepsy with public health perspective by Dr. Kalkonde sir. So I would request Dr. Gursani sir to start. Probably once director sir will come, I will just try to inform you in the meantime. So, sir, can you start, please? Gursani sir. Gursani sir, are you there? We'll wait 2 minutes for sir. Probably he might be joining again. So can you start, sir?
Let him join. He will be discussing the diagnosis. Okay. Yeah. So I think Dr. Roop is trying to rejoin, and so until then, we'll start with some case discussions. So this is first case. Beena is a 14-year-old girl, was standing for prayers at her school. She suddenly fell down. She got better soon, and the school teacher gave her water and some food. She has history of 3 similar events in the past. So what is the likely diagnosis and what will you do? Can we have comments by participants? Please unmute yourself and start speaking.
Can you hear to us? Is it audible?
Yes, you're audible.
Okay, great.
Yes, it's audible.
Yeah, thank you. So,
Hypoglycemia.
yeah, so please, yeah. So one, comment by Dr. Masood is hypoglycemia. Very nice. What else could this be? Can this be a seizure?
Hypotension,
Can this be a seizure? What is the other possibility? Like hypoglycemia is, one possibility. That's good.
postural hypotension,
Postural hypotension. Very nice. So what is it called? It's usually called a syncope, right?
yeah,
Right. So why this is not a seizure? Why you're thinking? So excellent differential diagnosis. Why this is not a seizure?
there are no movements of body limbs,
Very nice. There is no jerking of arms and legs. Very nice. What else? Is there any loss of consciousness that that is reported here in this case? So there is no loss of consciousness that is reported here. So these are the two possibilities. So what will do? I mean, these are common scenarios that you see in the schools. So what should the teacher do? Yeah. So what will you recommend teachers to do? Okay, good. ORS is one recommendation. If it is postural hypotension, how would you correct it?
we will lie down the patient and we will lift
Yeah.
her legs.
So if such a patient comes to you, family brings this patient to you saying that, she falls or he falls in the school again and again, what would you recommend? So all of you have made up your mind that this is not a seizure. So what will be your general advice to parents? They have brought the child to you for evaluation and comments. What would you suggest? You're on right track. So what would you recommend?
She should have some food before us.
Very nice. So maybe before she goes to school, the child should have some food. Good. What else?
I've just, yeah.
Yeah, Dr. Roop is back. So Dr. Roop, since you are joining, I started with one case discussion. So we are discussing this case of a child falling down repeatedly while standing in school prayers, and we are discussing the differential diagnosis. So one recommendation was the child should carry food. So more likely than hypoglycemia, this is more like postural hypotension or syncope. So the usual recommendation is the child should be well hydrated because many times they don't drink enough water. The second is they should not wear tight clothes. If they're wearing tight pants, then there is pooling of blood in legs, and so that's why the child can fall down. So first is the child should be hydrated well. Second, tight clothing should be avoided, and third is if this is happening repeatedly, then they might request the teacher that they would not stand in the prayers. They can just sit through the prayer period. Right. So these are common things, but all of you have picked up very nicely that this is not a seizure. So now we'll move on to Dr. Roop to he will be actually discussing the diagnosis of seizures. So we'll stop sharing here, and we'll come back to these slides again.
Yeah, just give me a minute. Can you hear me?
Yeah. So Dr. Roop will also be discussing how do you differentiate between a syncope and a seizure. And it's very important because, a lot of times the diagnosis of seizures is clinical. So you need to take good clinical history and you need to know what are the differentials or what are the mimics of a seizure.
Okay. Can you hear me? Is my screen visible?
Yeah, yeah.
Okay. So, thank you, Dr. Yogesh and Dr. Swapnil, for inviting me to speak here. Let me just put the slideshow on.
Your
Yeah,
volume is
so-
a little low. Can we up your volume a little bit, Dr. Roop?
Now, is this better?
Yeah, slightly better.
Let me see if I can make it a little better with the AirPods.
Yeah, it's getting better. It's getting better.
Yeah, just give me a sec.
Sure.
Right, now?
Yeah, yeah, better, much better.
Okay. So, I'm speaking on clinical diagnosis in epilepsy, and I will be covering seizures and seizure mimickers. And I'd like to thank Dr. Yogesh and Dr. Swapnil for having me here to speak with you today. So, I think the primary question that you face when you are uh, seeing a patient with this kind of situation, those that Dr. Yogesh spoke about, and those that are there in MCQs, is this or are these seizures? When we say seizures, we mean epileptic seizures. So when do you face this problem? The first situation is when the person has a first ever episode of transient loss of consciousness, and they land up in your OPD or casualty, and you really have to distinguish between syncope and epileptic seizures. But of course, you must not miss hypoglycemia, and typically this is somebody who is still confused or still has some neurological issues when they land up with you. The next situation is when somebody is having recurrent episodes. Even before they've come to you, they've had it 3, 4, 5, 10 times. And then you have to distinguish between the three main causes. There are others also, but these are the three that you need to tackle. And the last is you are with the patient and the patient starts to have something. And you have to decide what it is and how do you need to respond immediately. So let's first tackle the situation of transient loss of consciousness. What does a transient loss of consciousness mean? And I mean, typically people will describe this as chakkars. In English, people call it spells. But whatever it is, it means that an event has occurred during which the person has fallen down, usually has lost consciousness, and has returned to normal by the time they come to see you. So it's rapid in onset, it's short in duration, and it has a spontaneous recovery. And there are three main differentials which we've already listed: syncope, seizures, and psychogenic episodes. Right? Now, how do you take a history of this? Basically, you need a reliable eyewitness because the person was unconscious. They can't tell you what happened. So, first is, does the eyewitness know what they are talking about? Do they live with the patient? Were they there at that time? And then you try and recreate the episode. Where were you standing? Where was she standing? Walk through the episode. Okay, so you saw this, then you saw this, then you saw this. Very often, patients and families tend to mix up episodes. If there are 4 or 5 episodes, they'll give you a combined. You have to focus them down on one particular episode that they have clearly seen. In case you're not able to get a reliable history, then you have to train them to observe. And now with cell phone videos, you can get them to actually show you what they mean. And if there is a witness, and if somebody has fallen down, there is this rather famous study which gave short videos to a bunch of students and asked them what they saw. So in the top, the video shows a woman, tennis player. She's playing tennis, and suddenly, while she's playing tennis, she slumps to the ground and falls unconscious. In the second video, there is this woman again who's walking into a room, and she starts to shake, and then again she falls down, and her body stiffens, and she's lying in this position. And when they asked these guinea pigs, they were the so-called students who were asked to be the witnesses. Literally, the only thing that they remembered from the two episodes was that in the first one, the person slumped down and the body was loose. And the second, the person fell down and the body was tight. So, one of the things that I asked them is if they can tell me whether the person's body was loose or tight. Dhila tha ya kadak. How reliable is this sign? Well, it is reasonably reliable. Very often people will still tell you that, no, I couldn't figure it out. But often they can. And if you do get this answer, then you understand which is which. The dhila or the loose is the syncope, and the tight or the stiffness is the seizure. And of course, you have to ask the patient, was there something before it happened? Did you know something was about to happen? Did you hear people talking when you were down? How did you feel afterwards? When did you become normal? And of course, you have to offer advice about first aid, which we come to a little later. Now, when you look at these two major issues, syncope versus seizure, when somebody presents to the primary care or to an emergency department, you can look at this panel, which looks at multiple papers and put them together. And overall, what they seem to suggest is that close to 51% of these are cardiovascular, which means syncopal, and just about 14% are neurological, mainly seizures, but others also. So, in that sense, just by looking at the odds, anybody who suddenly falls unconscious, then becomes conscious and comes to you, is more likely to have a syncopal episode. Actually, if you look at it in the population at large, syncope is fairly common. 15 to 25% of the population will have it. If you look at epilepsy, it is not obviously that common, just 0.5 to 1%. But anybody who gets epilepsy is likely to have recurrent seizures. Anybody who has syncope may have 1 to 2, maybe 3 episodes. Most people will have just that many. So that perhaps gives you a perspective of what happens when a patient comes to you. There is only one thing to watch out for. When somebody becomes suddenly unconscious, especially if it is like that lady who was playing tennis, you have to think about the risk of sudden cardiac death, because there are hereditary arrhythmogenic syndromes where there's a family history of sudden cardiac death, when the precipitance is an exercise or emotional stress, or when the syncope happens in sleep, and then when there are no warning symptoms. So these are the situations where most situations of syncope are benign, but if you find this, then this is something that needs a cardiac opinion. And there is one more point that you need to do when you're sorting this issue out. It's not always present, but if it is present, it is 100% specific for a seizure. This is the lateral tongue bite. This is because when a generalized seizure begins, the body goes into the tonic phase, and when the tonic phase happens, the jaw tightens and they bite the lateral part of the tongue. And this is almost always a seizure. Right. Now, the thing is, there are multiple types of seizures. We'll be discussing this. But of these various types of seizures, generalized tonic-clonic seizures will present with the first episode. It's just too dramatic. Nobody misses it. One fit, and they'll be in your OPD or casualty immediately. But there are minor seizures. They are complex partial, they are absences, they are myoclonic, and I'll be showing them to you. They are often ignored. And often nobody notices that they have happened until about 5 to 6 episodes have passed, and suddenly people notice, what is this person doing? Or you have to actually identify them by direct questioning, mimicking, showing them, is this what happens? And then they say, yes, these have been going on for some time. When somebody has a solitary episode, if it is a solitary seizure, now in the panel on the side is what you would do under the best circumstances in a tertiary center, maybe in a private hospital. There's a whole list of things that you need to check, including the CSF, drug screening, and so on. Do an EEG quickly, do an MRI. But at the primary level, let me assure you, the most important tests are just those that I have listed. A CBC, sugar, sodium. And if you have available a CT scan. I think now CT scans are available at the district level in all across Maharashtra and even at taluka level. So I think you should get a CT scan at the head. And if there is a single seizure, well, remember that all of us have a 5 to 10% risk. Although the actual figure is 4 to 8%, I think it's probably a little more. But up to a 10% risk of a single seizure from birth till the age of 8 years. How likely is it that it will recur? Well, if it occurs as part of a febrile illness like febrile seizures or even later in life, then the risk is only 3%. If it is because of an acute brain injury, this may be a stroke, this may be a head injury, then again the risk is just 10%. But if the fit occurs without any obvious cause, then the risk of recurrence is as much as 40%. And if a second unprovoked seizure occurs, you can accept that this is somebody who has a tendency to epilepsy and probably will go on to have multiple fits. Right. So we are moving now from the single episode to recurrent episodes of transient loss of consciousness. And when you look at these, again, you literally have to make the same differential that we did earlier, but now I'm going to go into it a little more detail. And you have to remember that now the witnesses will also be more geared to finding out and to analyzing these episodes. When you take the history, remember, there are some features in the background. For seizures, in somebody who has multiple seizures, they are fairly frequent. They're not too many. It's only about 1% of the population that gets them. But there is a background of some kind of neurologic issues. So there may be alcohol, drug abuse, prior head injury, previous sinus infection, febrile seizures, stroke, or a family history of epilepsy. Any of these will predispose that individual to getting seizures. That does not mean that these are seizures, but still something you keep in mind. For the syncope side, remember that these are much less frequent episodes, but much more common in the population. And these are often patients who are older, may have cardiac disease, or maybe on anti-BP or BP medicines. What precipitates these episodes? Well, seizures often occur in relation to sleep. So in sleep or with sleep deprivation. Alcohol withdrawal is known. Endocrine hormonal changes such as menstruation is another factor. And some children may get seizures when they see flashing lights. What about syncope? So postural change, when somebody is lying down or has been in bed for a long time and suddenly stands up, their blood pressure may not match. The second is neck movements. Older people often have carotid body hypersensitivity. And sometimes they may even have disease there due to atherosclerosis. And then when they turn the head on that side, temporarily they get bradycardia and they can get a syncopal episode. You've heard of people who get, often again older men, who get up in the middle of the night to go and pass urine. And as they are passing or just as they finish passing, they literally pass out and they fall down. And within 15-20 seconds, they are up and about. Micturition syncope occurs because, when you get up from bed, your blood pressure is a little on the lower side, you pass out urine, again the blood pressure drops and then it just drops a little too much. And the response of the body is to maintain the circulation to the brain, so the body has to be made flat. Heat, prolonged standing, yes, we all know that, like the example of the child who was standing at school assembly. And occasional people are very sensitive. These are called vasovagal episodes, and they can happen with something that is emotionally stimulant, like blood collection. Okay, when the seizure begins, often in focal epilepsy, there is a stereotyped aura. It's brief. and it represents excitation of the part of the cortex where the seizure is beginning. And I will be showing you some examples of that. One very common one is a rising abdominal sensation, as though something is coming up from the stomach in the chest. And just before they feel that they might vomit, they lose consciousness. On the syncopal side, typically these are symptoms that occur because blood pressure is dropping. So they feel lightheaded, there's darkness, डोळ्यासमोर अंधारी, or blurring of vision, or then there is a buzzy echoing like you are in a big space, and they start feeling cold and sweaty. And this may go on for about 15, 20, 30 seconds before the person actually falls down. This is very different from an epilepsy prodrome, where people who have long-standing epilepsy often know for hours or a day that they are likely to get a seizure. Syncopal episodes will not be longer than a minute or so, and the aura also will not be longer than that. Right. Then what happens during the episode? During the episode, because the person has, during the tonic phase, a kind of a respiratory arrest, they'll be a little cyanized, a little, not too much. Sometimes they may pass urine. I've already told you about the lateral tongue bite. And when they wake up, because they have had all these strong body movements, they will have headache and body ache. And sometimes, if there is a particular part of the cortex that has been playing a lot of mischief during the seizure, it may temporarily be not function. We call that Todd's paralysis. Exactly on the other side, on the syncopal side, here, in fact, the body becomes cold and pale. Incontinence is rare. Occasionally, people with syncope may fall forwards and get injured on the lips of the anterior tongue. The important thing is post-ictal. Immediately after the episode, somebody who has syncope will be instantly and completely normal. Now, one thing that you may have been told is that if somebody gets jerking movements, then it has to be a seizure. Let me add a little bit of nuance to this. There's a little bit of something that you need to be aware here. Now, these were taken from somebody who had a tilt table testing, in which you try and induce syncope, and here, because it happens over a period of time, they could video it and watch. And what they realized is that many people who became syncopal had a little bit of stiffening of the body and a few jerks. Now, few jerks, now that is the important thing. And then somebody actually took the trouble of comparing patients with syncope and with seizures in the beginning to look at motor movements. When somebody with syncope has jerks, those jerks are always less than 10. So how do I use this? When somebody says ki ती पडली आणि त्यानंतर हातपाय हल्ले, so I ask them किती वेळ, and they think back and say, oh, 3-4 वेळा. If they can remember and if they can think, I mean, if they can give you a count, then obviously it is likely to be less than 10. Whereas if it is a seizure, they say 9. I could not figure out. They हातपाय continuously halat hote. So if somebody says that the body stiffened and there were a few jerks, ask them how many, and if they were countable, then it is still quite likely to be a syncopal episode, right? So just remember this point, that even in syncopal episodes, you may get a few jerks. In a seizure, the jerks are uncountable. They will just be going on very fast for almost a minute or so. Right. So you get this patient, whether it is recurrent episodes or the first episode, some investigations have to be done. Basic investigations would be CBC, sugar, kidney function, liver function, sodium, potassium. Of these, I think a CBC, a sugar, and a sodium are mandatory if this is the first episode. Absolutely mandatory. What about an EEG? If you have the facilities, yes, do a routine 20-minute EEG. If somebody is getting recurrent episodes and it is not possible to control them, then we do a prolonged EEG, maybe 2 hours, 4 hours after overnight sleep deprivation. Almost every patient I would do a 12-lead ECG, especially in adults, because you need to be sure that you're not missing a conduction problem. Right. And then if there is any doubt that this is syncopal, then you will need cardiac investigations, echocardiogram, and then there's a special test called tilt table testing, which is available only in tertiary hospitals. We do it obviously regularly, but well, it's not something that you generally need to bother about. So, come back again to the investigations. At your level, at the primary level, CBC, sugar, sodium must be checked, and a CT scan head must be done, and you must start anti-seizure medication. And this, of course, Dr. Yogesh will be taking further. Further workup is really required only if the seizures are not controlled. If you remember the single seizure, well, if I told you that almost up to 10% of the population get a single seizure. So do you call this epilepsy? Dr. Yogesh will be discussing this, but we call this epilepsy when there are 2 or more unprovoked seizures occurring more than 24 hours apart. Why 24 hours? Because we believe that within 24 hours it is the same pathophysiology, so you cannot count them separately. Or if you judge based on the investigation, like you have seen something on the CT scan or the MRI, and you think that the likelihood of this patient getting fits again is more than 60%, then again you can make a diagnosis of epilepsy. Or if the person has a very specific kind of seizure, say something like complex partial or myoclonic, and I'll show you those, where you can actually say this particular seizure means this particular kind of epilepsy syndrome. Again, you can make a diagnosis. So when somebody gets a first seizure, a single seizure, from the figures that I showed you earlier, you know that not everybody will go on to get epilepsy, but about 60% will keep getting more seizures. 1, 2, 3, and a good proportion of them, about 2/3 of them, you give any one medicine and the fits will just stop. And that's, as you can see, that's a fairly large chunk of patients who get managed this way. But 1/3 of them will not or will continue to have fits. And those are the ones that we call chronic epilepsy. Here you may need to give a combination of anti-epileptic drugs, or you may need to, I think you often will need to refer them to a tertiary center for further management, either with medication, surgery, whatever. And this evolution can take as long as 3 to 5 years. Now, when we look at seizures, epileptic seizures, it's important for you to understand a little bit about seizure classification, especially because it has changed a bit in recent years. I'm not going to go into the details of that, but you know that seizures can be either focal or generalized. And some terms that are now not commonly used, for instance, petit mal is now replaced by absent seizures. Focal simple partial seizures, where somebody just gets jerking movements and still remains conscious, are focal aware seizures. Somebody who gets what we used to call a temporal lobe seizure, and I'll be showing that to you, is now called focal impaired awareness. And then you have grand mal or major motor seizures. The term now is generalized onset tonic-clonic. You may get a focal seizure which goes bilateral, that becomes focal to bilateral tonic-clonic, or if you don't know, then unknown onset. To take these details, you need to know the events before the seizure. You need to, sorry, I just need to respond to this. Just give me a minute. Right. The aura I've already told you about, the tongue bite, postictal, and of course the drugs that have been used. And then with the eyewitness, you need to walk through a personally witnessed episode. Sometimes you will see these, you can actually mimic the event and ask, is this what happens? And if not, then ask them to get home videos. So let's start off with the first kind of seizure. Now you will see that this schematic shows you an abnormal bit of cortex. Now this abnormal bit of cortex on the right side of the brain, as it begins firing, the area, the muscles that are controlled by it start to jerk. And then as it spreads, more and more muscles start to jerk. Sometimes it may even go to posturing. If it is not the motor, if it is a sensory cortex, they may get odd sensory symptoms. Let's see it on the video. I'll reduce the volume. She's beginning to get some funny symptoms here, but and then you can start seeing this little jerking that is happening here, right? I'll just fast forward a bit. See the jerking? The jerking is beginning to spread. You can see it is going up into the shoulder here, and now the whole shoulder is jerking. And she's still conscious. She's still talking through it. This is because the area of cortex that is involved is not that much that she becomes unconscious, and then it starts to reduce. Sorry, a little further. Last, yeah, there. It has finally reduced and stopped. And at this point, he was able to move the arm, but when we examined it, it was flopping. Right. So this is what you call a Jacksonian seizure, where it used to be called focal or simple partial. We now call it focal aware seizure. Dr. Sapnil, Dr. Yogesh, you were able to see this, no? Hello?
Yes, yes, we are able to see the video very well. Thank you.
Oh, right. So the next one. Now, this is a seizure that occurs in the parts of the brain that control your consciousness. So the temporal lobes and the areas around that. And the discharge begins here. As the discharge begins, literally, one of my patients said, my brain hangs and then restarts, like the computer or the laptop or the phone. Because these are areas that control consciousness and memory, the person has no recollection for the event. And during this period, they are still not doing anything or doing something automatically, repetitively. Sometimes they may have bizarre movements of the legs and the hands, and again, not be aware of that. Unlike the previous one, this video came from a video. Now, her child is crying. She's completely out of it. He doesn't even look at the child. And then you see the father coming up, who's actually taking the video. He comes and picks up, and she's completely unaware of this. She wiped her nose with one hand. That's one automatism. This hand is not moving. Right. Another one. And here, just to point out that many of these patients will have these automatisms. It will be difficult. I'm not sure if you caught it. There's also a little bit of movement of a mouth. And she keeps. Now, the thing is, in this patient, the automatisms were on both sides. So, which makes it a little difficult for us to look. But whatever it is, these are repetitive, patterned, semi-purposeful, spontaneous movements which occur because lower brain levels are released because the cortex is kind of stopped. One more. And as you can see, these have been recorded on a cell phone. Unlike the first patient, which was in the EEG laboratory, these are by eyewitnesses. Here you can see a little something interesting. His right hand is stiff, while with his left hand, he's making these movements. This right hand stiffness tells us that this was arising from the left side of the brain. And eventually he underwent, his left temporal lobe was removed and he's now seizure free. Right. So now you've seen the complex partial seizures where the episode is in a restricted part of the brain which controls memory and, in a sense, temporarily halts the rest of the cortex. What happens is these are short episodes where the whole brain fires, but not to the point that somebody loses consciousness and falls down. We call these absence seizures. Typically, absence seizures occur in younger children. They occur towards the first decade, maybe in the second decade, and by adolescence, they are gone. The EEG is typically abnormal. It shows something called a 3 Hz spike in wave. And these are episodes that are precipitated by hyperventilation. So in the EEG laboratory, as you will see here, if you make the child breathe deeply.
Don't stop.
We asking her to take deep breaths.
Morishka, show me your tongue. Show me your tongue. Look at me. Morishka, what's your name? Tell me. Just take this. Oh,
Yeah,
very
so
good.
now Morishka
What's
is
the
woken up.
Very good. Okay,
Okay.
now.
So you saw this. About 5-7 seconds, she was out.
Close your eyes.
But she seemed awake, right? So those are absence seizures which occur in younger children. And they have to be distinguished from the ones that you saw earlier, the complex partial seizures. Absence seizures are short, less than 10 seconds. Whereas if you remember this one, this was much longer, right? Right. One more type of seizure. These are myoclonic seizures. Myoclonic seizures are sudden, brief, shock-like episodes. Though, in a sense, the whole brain fires, but a very short period, just this much. And during this period, if you do manage to catch them on the EEG is always abnormal. There are two major causes. The first are called epileptic spasms. These occur in very young children. Typically, it starts under the age of 1. And it can go on till, like in this patient, till in the later part of the first decade. But typically, they start off in under the age of 1. And here, they are associated with severe brain damage. And these are children who will have lots of neurologic problems. In fact, they become very dependent unless these can be stopped early. As opposed to these other kind of myoclonic drugs. These are juvenile myoclonic epilepsy. And here the person is completely normal, except just this much. You can see this again. Just watch. One single jerk. And these often occur in the early morning, jerking of arms, shoulders, head, the toothbrush flies off. It's also been called the flying saucer syndrome. Cup of tea and it's thrown away. Right. Now, all of these are, in a sense, minor seizures. But for us, the most prominent is the generalized tonic-clonic seizure, which is the 5 common pathway. This consists of, we've discussed the prodrome, the aura, and then this is followed by the tonic component. Now, the tonic component is the one where injuries occur, consciousness is lost, jaw and paraspinal muscle contractions, so they will get the tongue bite, and the paraspinal muscle contraction can actually lead to the rib and vertebral fracture. This is where the epileptic cry happens. And then they get cyanosed. It usually does not last more than 30 seconds. This is followed by the clonic phase. There is a tremor-like generalized jerking. There is salivation, respiratory contractions. They make grunting sounds. Incontinence will occur at that time. And this also lasts about 60 seconds. And this is followed by the post-ictal stage of diffuse hypertonia, confusion, delirium, headache, muscle soreness, TOTS paralysis, please see that the generalized tonic-clonic seizure rarely lasts more than 2 to 3 minutes. Why is this important? Because in some ways, generalized tonic-clonic seizure is literally a part of the repertoire of the normal brain. And because it is a part of the repertoire of the normal brain also has mechanisms to stop it. So 99.99% of generalized tonic-clonic seizures stop spontaneously. And these generalized tonic-clonic seizures can be primary, meaning the whole brain starts to fire. And they can also be secondary. So somebody may get a discharge, say for instance, in one temporal lobe, this spreads across to both temporal lobes, and then it spreads across to the whole brain. So let's see this. He realizes something is about to happen, and he's holding his head. And in fact, our technician, I think, is not there at this moment. This is the epileptic cry. And then the jerking begins. Here, the tonic phase was probably very short, and that was the cry, and this is the clonic phase. And then he obviously falls down. Fortunately, there was no injury, but this is the clonic phase, and this is what you are most likely to see. Typically, when you come in, you will see the clonic phase. Now, in addition to this, although you may not usually see this, this is something that you will be getting on the history. Once in a while, you may get people who have functional or non-epileptic psychogenic seizures, and if you're not careful in taking the history, they can actually fool you kind of. So, and people with epilepsy can also get psychogenic seizures, so you have to be careful about overlaps. The first is watch out for a history of precipitation by stress, meaning they had some kind of quarrel or somebody fired them, and immediately after that they get the episode. The second is psychogenic or functional non-epileptic seizures tend to be prolonged. Remember that I told you that the generalized tonic-clonic seizure physiologically cannot last longer than 2 to 3 minutes. So if somebody gets shaking continuously going on for 20, 30 minutes, well, either they are in status or it is not a seizure. Another thing that you need to remember is that a seizure, if you look at even the last one, which was so dramatic, it has an evolution. It starts with one thing, then goes on to another, then does one more thing, and then it finally goes down. Whereas in psychogenic seizures, they tend to be doing the same thing throughout. So eyes will be shut and they are completely unresponsive. Or they may be getting these rhythmic tremor or raga-like movements which go on continuously. Or they may get complex movements, including pelvic thrusting, violent movements. Be careful because there are some complex partial seizures where violent movements can occur, and the difference is that those are usually very short. They rarely last more than about a couple of minutes, whereas these can go on for quite a while. And occasionally some patients may only tell you that they are getting odd sensations on one or the other part of the body, and well, they may be a kind of a seizure, but more likely they're not. And again, you have to distinguish non-epileptic seizures from panic episodes. So in panic episodes, this person will complain of anxiety. They may have a history of migraine. And typically, the episode begins with ghabrahat. Because they get ghabrahat, because they get hyperventilation, they say they are feeling breathless, but they're actually hyperventilating. And paresthesia can produce carpal spasm. Once in a while, they may even get a syncopal episode because of that. But the important thing is that you can identify hyperventilation and anxiety right in the beginning. So, I'm now on the last segment of my talk. What happens if an epileptic seizure occurs directly in front of you? Remember that this is something that families will ask you also, and this is something that you have to answer. What do you do when somebody has a fit in front of you? The first is, do not try to open the mouth during the seizure. Do not try to put things into it. Do not put a spoon. Do not put a tongue depressor. This is because if somebody is going to bite their tongue, they will have bitten it by the time you even get to the patient. And all that you should do is see that they don't injure themselves. Make sure that they are safe, and let the fit finish. Let the clonic seizures finish. It should finish in about 2 minutes. Then you roll the person over into a semi-prone position, and preferably with the mouth down, so that if there is any saliva or even if there's blood, it will come out. The tongue will not fall back. Ideally, make sure that the breathing is clear. And if they start to wake up, do not try to restrain them, because of a few minutes they may be extremely agitated. And if you try to restrain them, there may be violence. The one thing to remember, and you have to watch the time. By the time you reach it, it's likely that at least half of 1 minute is already over. And if the person still goes on jerking at 3 to 5 minutes, remember, this is verging into status. Now, earlier, when we used to read the definitions of status epilepticus, we used to say when 2 fits occur and the person doesn't regain consciousness, or somebody fitting for more than 30 minutes. That is gone. Why is that gone? Because we know that physiologically, a generalized seizure ends at 3 minutes, has to end at 3 minutes. If it lasts longer than 5 minutes, then the normal brain mechanisms that arrest seizure have failed, and this is now status. And you have 2 options that you can give immediately. If you have an intravenous line, then you must give 4 milligrams of lorazepam. If you do not have an intravenous line, then for an adult, you must give 10 mg of midazolam. You can give it subcutaneous, intramuscular, anywhere, just give it. Very often we underdose, and I'm repeating these doses. 10 of midazolam if it is non-IV, and 4 of lorazepam if it is IV. This is for a full adult, meaning 50 to 60 kgs and above. Right? So this is what happens, what you have to do if you are watching. I'm going to stop at this point, and I'm happy to take questions. If I think Dr. Swapnil has my presentation, but this is my email ID and my mobile number. You're free to even WhatsApp. So what I'll do is, unfortunately, I'm not able to, my laptop camera isn't working. So I'm going to try again to log in from the mobile if there are any questions, or if there's anything in the chat box, I can take it from there.
Thank you, sir. Thank you very much. Any participant has question about sir's presentation? Wonderful insights given by sir. You can talk also, no problem. You can just unmute and talk.
Thank you, Dr. Rajendra.
Sir, one question is there on
Good.
chat box, that
Yeah.
how to difference between panic attack and seizure both. So what is the difference between these two?
That is seizure.
Yes, sir. Panic attack and seizure.
So panic attacks typically they take some time to evolve. That person will have a history of similar episodes in the past, and the wonderful word that describes it is ghabrat. So the ghabrat starts first. The ghabrat is followed by hyperventilation, and then when they hyperventilate, because they get constriction, they start to get some amount of numbness in their hands and feet, and then sometimes they may feel a little giddy. Now, the the overlap between panic disorder and seizure disorder is something that Dr. Yogesh may be speaking about. Remember that people with epilepsy have a high tendency of psychiatric comorbidity. Anxiety and depression are, well, they are like almost 40 to 50%. What is the safest drug in epilepsy? Sorry, next session. You have to sit and wait till Dr. Yogesh finishes.
So she has Ashwini has saying that she has a patient with panic disorder and seizure.
So that's quite likely. But you have to treat both independently, ideally.
Yes. Okay, so pretest we are going to discuss later on. First, Kalkonde sir will be taking session, and at the end of the session, we will discuss about all these questions. But it's mandatory for everybody because almost only 20 to 25 people only solve the pretest. So we are expecting all participants to solve the pretest. So please do that. I already put the link on chat box 3 to 4 times, right? So thank you very much, sir. Please be with us for some time, so that once sir Kalkonde sir will complete a session, we'll again some questions will be there. We'll just address those questions.
So what I'll do is I have to go and see a couple of patients. I'll come back in about half an hour. Then I'll join you again.
Sure, sir.
That's fine.
Yeah.
Okay, sure. Thank you.
Thank you so much, Dr. Roop.
Thank you, sir.
I'll join again.
Yeah.
Thank you. So I would request Dr. Kalkonde sir to continue with the session. Some questions you will be having. Meanwhile, you can put your questions in your this chat box. So we'll address it after some time. So when Dr. Roop sir will come back after some time, we'll address these questions together along with Dr. Kalkonde sir. So thank you and welcome, sir, again. Just to continue your presentation.
Yeah, so we started with this case, and Dr. Roop also discussed this. This was most likely a case of syncope, and we discussed what to do in case of syncope. Common among school-going children, and usually it is caused by dehydration and postural hypotension. Next. Okay, now let's start with another case. So Raghunath is a 32-year-old male patient who was brought to casualty with a single new onset tonic-clonic seizure, which has stopped. The patient is alert and oriented. There are no focal neurological signs. What will you do? So some of what needs to be done has been discussed by Dr. Roop. So can some of you sort of comment as to what you would do?
So you can unmute and you can talk, because that will be very good. So it will be an interactive session again. So you can talk directly with Dr. Kalkonde sir.
Yeah. So we had a very nice discussion on case 1. So let's have some discussion on case 2 as well. So one option is just tell patient go home. You don't have to worry. This is okay. Will you do that? Yeah. Can someone unmute and comment? Whatever your comments are. Okay, there is something in the chat. So let's see. Basic investigation. Very nice, Dr. Masood. So you would, as Dr. Roop mentioned, that first thing you would do is check glucose. Hypoglycemia can cause seizures, and then check CBCs, see if anything is abnormal. What is the other concern that we have if the patient has seizures, which is more serious concern, that this could be because of something else in the brain which could be serious. So what other investigation would you suggest to this patient? Dr. Roop mentioned this, and feel free, if you cannot talk, just type it in the chat box. Very nice. So brain imaging of some sort, right? Very nice. So CT head, and we'll come to it. So wonderful. So these are 2-3 things that you would do. Next, please. Now there is another patient, and these are all patients seen in primary care. So you're going to see these kind of patients. So there's a 2-day-old girl child who was brought to the casualty with 2 episodes of uprolling of eyes and jerking of hands and legs. Child is drowsy. Temperature is 100 degrees Fahrenheit. What will you do? So does this worry you? Is this worrisome, or this is normal? You can take your time and do things, or this is something urgent? Please type. I mean, some of you are typing, so please type. Okay, okay. So one thing is it could be febrile seizure, febrile convulsions. Okay, good. Right, but right now the child is drowsy. She already had those episodes. And how common are febrile seizures at the age of 2 days? The child is only 2 days old. Good. So, you had typed this. So this is, we'll come to febrile seizures. What's the typical age? So this is not a typical age for febrile seizure. So any 2-day-old child who's getting, seizures, and, someone has very nicely mentioned calcium and blood sugar, levels. So very nice. So please do get, if the child is less than 6 months old, please do get investigations like in the form of blood sugars. If you have access to calcium, get CBCs, because, there is history of fevers. So this could be meningitis, right? Very nice. Next. Now let's, Dr. Roop also mentioned what we have to differentiate is this a seizure or is this an epilepsy? So seizure, why does seizure occur? It occurs because of uncontrolled electrical activity between neurons. And usually it causes temporary abnormalities in muscle tone, movements, behavior, sensation, or state of awareness. And as Dr. Roop mentioned, typical seizures are, they last from 30 to 60 seconds. Most of the seizures are over by 2 minutes. So that is this is a temporary activity. Next. So one thing we need to understand that seizure is manifestation of some underlying illness, just like fever is manifestation of some underlying illness. So you can have fevers because of infections, you can have fevers because of inflammation, you can have fevers because of malignancy. Similarly, seizure can occur because of something, some underlying problem. So it's like a manifestation, it's a symptom of some underlying, disease. So seizure in itself is not a disease, it's just an external manifestation. Next. So what are the common causes of seizure? So one mnemonic, if you want to quickly remember, is something called as vitamin. So V is for vascular. So you can have stroke, subarachnoid hemorrhage can give you seizures. Infections like meningitis, encephalitis, TB, scrub typhus, dengue can give you seizures. Trauma like traumatic brain injury, subdural and epidurals. We see a lot of these patients who come after road traffic accident. AV malformations. Then metabolic causes like you can have low glucose or low sodium or low calcium. All of them can give seizures. Or there could be idiopathic causes where we don't really know what is causing seizures, and neoplasms or brain tumors. Next. And this is again a longer list. You can go through that, and as you can see, the metabolic causes will cause seizures. They will not cause epilepsy. So we come to causes of epilepsy. Next. And so, how do we differentiate seizure from epilepsy? Epilepsy is recurrent attacks of seizures, right? And as Dr. Roop has mentioned, if they are occurring more than 24 hours apart, then they are called as epilepsy. And this indicates there is something abnormal in the brain, which puts brain at the risk of having these recurrent episodes of seizures. Next. So for all practical purpose, if the patient has 2 or more unprovoked seizures 24 hours apart, we call it epilepsy, right? So when we say unprovoked seizures, we need to understand what are provoked seizures. So provoked seizures are febrile seizures. So if the child from the age of 6 months to 6 years has a fever, then there is a likelihood that the child might get a seizure, and that is called a provoked seizure because of the fevers. Or someone has meningitis, then it's considered a provoked seizure. Or someone, a patient, diabetic patient who's on insulin or oral hypoglycemic agent, suddenly has a seizure, then, which is precipitated by hypoglycemia, then it's a provoked seizure. Or following head trauma. So if someone has head injury, then within first 7 days, there is high likelihood of having a seizure. Or following alcohol withdrawal or heavy alcohol ingestion. So if someone is drunk and gets a seizure, we don't call it epilepsy. It's a provoked. We know that there is a provocating cause here. So it's called a provoked seizure. So any seizure that is not provoked and it is occurring 24 hours apart, we call it epilepsy. Next. So is it a public health problem? The answer to this is yes, it's a public health problem. So what's the prevalence in India? Prevalence in India is from 2.5 to 10 per 1,000 population. That means if you are working at a PSC, which has a typical population of about 20,000, then you would have anywhere from 50 to 100 patients in your area, right? But most of the patients may not come seek care, because we know there is something called as treatment gap in epilepsy. The first place where patients with epilepsy go is some a person who does jadoo tona, because this is considered something externally possessed. So they typically don't come, they don't get medical care. And the prevalence of seizures is more in rural areas compared to urban areas. So this is also, all of you work in primary care, healthcare setting in rural areas need to know this. Next. So what causes epilepsy? So there is some abnormalities in the brain which could include chemical imbalance, structural abnormalities, and a lot of these structural abnormalities may not be seen on the MRI or the best scans that we have. So some abnormalities we still don't have technology to see or pick up those those abnormalities in the brain. Next. So causes of epilepsy, you saw they are similar. Causes of seizures and epilepsy are similar, except the metabolic causes are not here. So hypoglycemia typically doesn't produce epilepsy, or hypocalcemia typically doesn't produce epilepsy unless it's part of some genetic syndrome. So other than those, these are the things that can produce increased risk of seizures. So we discussed brain tumors, and that's why we want to do brain imaging, because sometimes patient can have up to 10% of the patient can have some brain abnormality which is producing seizures. So if there is a patient with seizures and you don't do brain imaging and there is a tumor which gradually goes, then you will be missing out on the tumor. And that's the reason we propose that patients should be investigated with brain imaging. Next. And the key question for you is this a short-term temporary problem in the form of seizure, or is this a long-term problem, which is epilepsy? Because then the treatment varies, and we'll come to that. Next. So what are the things that we need to ask? As Dr. Roop mentioned, epilepsy is a clinical diagnosis. So we need to take good history. And most of the times the diagnosis of epilepsy is based on history itself. Next. So what are the key clinical features that distinguishes seizures from other non-seizure events? So one thing is it's sudden onset. Then you will have same type of, by and large, you will have same types of events. And these are called stereotypic, meaning that same events occurs again and again and again. Then, as I said, it occurs in episodes, so short lasting episodes. So that's why it's called paroxysmal. Then the patient would have fall or other injuries. There would be lateral tongue bite that Dr. Roop mentioned. Urinary incontinence is again common feature of seizures. And one important thing is there is gradual recovery. So when the patient has syncope, the patient falls down and immediately the patient recovers. While in epilepsy, it takes 2, 3, 5 minutes, sometimes up to hours or days for the patient to recover. So slow recovery, if you're taking history and then you ask like patient, ekdam tabadab ठीक झाला का? And when they say कि नहीं हळूहळू ठीक झाला, so that favors the diagnosis of a seizure. And no memory of the event. So usually, unless it is partial seizure, patient does not have any recollection of the event. They will not remember. So in a generalized tonic-clonic seizure, patient will not remember that they had a seizure. Next. And as Dr. Roop mentioned that, seizures, some of the patients might have aura. So they know that there is something, that is going to happen to them. Then you have the ictus or actual seizures, which last anywhere from 30 to 60 seconds. Longest is 2 minutes. So usually it stops before 2 minutes. And then there is a post-ictal phase where after the seizure, the patient could be confused. Sometimes the patients get agitated. Sometimes they get aggressive, or sometimes it's just mild. Patient recovers and is mostly back to normal. So clinical features of seizures, as Dr. Roop has already mentioned this, so we'll go fast. It depends on where the lesion is or where the problem is. So if the problem is in one particular area of the brain, you will have manifestation only from that area. Next. So this is something called as homunculus. So body is mapped. So if there is for example, there is a brain tumor in the hand area, and if the patient is going to have seizure, they're going to first start in the hand. And if that excessive electrical activity is going to spread to other areas, so you can see that it could spread to arms and then shoulders and trunks and knees. And it could also spread to other parts of the head. And then, so patient can have what is something called a Jacksonian march. So, the symptoms evolve. Next. And, commonest symptoms that we have are motor symptoms. So you can have, tonic-clonic activity. Very rarely the seizures are sensory, where they only have tingling or numbness or abnormal spells. And then there are, seizures where there will be abnormality of consciousness. So what Dr. Roop has discussed, that focal seizures with impaired consciousness. Next. And these are the terminologies that we use. Like tonic seizure is when there is tightening of extremities. Clonic is when there is jerking of arms and legs. Tonic-clonic when it is mixed, both tonic and clonic activities. And these are old terms like complex partial seizures, where patients have loss of, the awareness is lost. The patient is conscious, but awareness is lost. There are some seizures called atonic seizures, where there is suddenly loss of tone in the entire body and the patient falls down. And myoclonic, which the video of which we saw, that sudden brief jerking or contractions of the body. Next. And this we already discussed, so I'll not repeat this. Next. So when you are, when you got history which suggests that this could be epilepsy, ask for the risk factors for epilepsy. So is there a history of head injury? So if the child presents at the age of 14, 15 years, ask whether there was any head injury that the child incurred where there was loss of consciousness. History of stroke would be important in elderly. History of CNS infection like meningitis or encephalitis. So again, in children, it could be important that as a child, if they had this severe illness where the patient had high-grade fevers and loss of consciousness, then the child could have suffered from meningitis, encephalitis, sometimes cerebral malaria. Ask about history of alcohol use and withdrawal. Ask about history of birth asphyxia. Ask about history of any other tumors that the patient had. Or if the patient has dementia, meaning memory loss, there is increased risk of having seizures. And if the patient is a child, ask whether these seizures occur only when the child has fevers and not otherwise. So these are the important history points that you would keep in mind. Then there is also, among patients who have epilepsy, there are certain things that increase risk of having seizures. And the commonest, risk factor is missing medications. So patient with seizure who's taking medication misses 1 or 2 doses, they can have seizures. So check with them whether they missed any dose, because if they missed any dose, you don't have to increase the dose of the medication that they are on. But if they're taking it regularly and still having seizures, then we need to go and increase the dose. Lack of sleep is a known risk factor for having a seizure. Mental stress, precipitates seizures. Alcohol use will precipitate seizures in patients with epilepsy. Next. And then also look for consequences of having seizures. Seizure can be, can induce sometimes life-threatening injuries. So they can have falls, they can have fractures, they can have lacerations, they can have burns. This is very common in rural area that patients present with burns and contractures. Drowning is a real risk in rural area. If the patient is not on seizure medications, they go in water and they suddenly have a seizure and they drown. Memory loss is an issue. If the patient is having recurrent seizures, they have memory loss. And they also have a lot of psychiatric comorbidities in the form of anxiety or depression. So ask for them. And if patient has symptoms of depression, you need to treat that as well. Then there are certain red flags that you need to look for. So what are the red flags? These are the symptoms or signs which increase the risk that there could be something very serious going on in the body. So for example, someone is reporting worsening headaches and vomiting with seizures. So that clearly indicates that these are signs of raised ICT, intracranial tension. So you will have to immediately go for brain imaging and see if you're dealing with any brain tumor. Head injury or burns during seizures tells you that if someone has sustained head injury, then look for, if they are going to have risk of epidural or subdural hematoma. So you'll have to keep an eye on them. One-sided weakness that lasts more than few hours. So as Dr. Roop mentioned, there's something called as Todd's paralysis, which is a transient weakness that lasts on one side of the body, which usually improves in a couple of hours. But if it is not improving, then there could be underlying problem like stroke, or there could be a tumor. Seizures that are lasting for more than 5 minutes indicate that the patient is at higher risk of going into something called a status epilepticus. So that is something that you have to ask for. Or if there is increased frequency of seizures recently, then you need to be, watchful and manage the patient appropriately. What are the comorbidities that the patient with epilepsy might have? They could have intellectual disability. In the rural area, we commonly see a patient with mental retardation coming with seizures. Behavioral disturbances, again, you could see that with seizures. Cerebral palsy, I already mentioned. Autism, vision impairment, hearing impairment, or some of the children with seizures might have ADHD, attention deficit and hyperactivity disorder. Or if the seizures start at very early age, then there could be feeding difficulties as well. So then we ask this history. Now let's go ahead and do assessment and evaluate and clinical examination. Next. So you don't have to do detailed neurological examination in primary setup. So primary setup, quickly you should look if the patient has any focal neurodeficit. And one of the quick ways of doing that is ask the patient to close the eyes and hold both the arms up. And if you see one of the arms is dropping down, then that indicates that there is something abnormal on one side of the brain, right? So this is called as pronator drift. So ask the patient to close eyes, hold the arms straight at the same level, and if one of the arms is going down, patient could have something abnormal on one side. You can quickly check if pinprick is equal on both sides. So if it is unequal, then again, that tells you that there is something wrong in the brain, and in such patients, you would immediately go for brain imaging. Or there are abnormal reflexes on one side. So again, that tells you that something is abnormal in the brain. If the patient is taking seizure medication, then look for nystagmus. Nystagmus is ask the patient to look to one side, and you see the bobbing of the eyes. So that indicates that the patient is developing some toxicity because of the anti-epileptic medications. Ask them to walk in a straight line. If they have difficulty walking on straight line, that's also another side effect of dilantin and carbamazepine. So you might have to reduce the dose. Look for hand tremor. Ask the patient to just put the hands forward, and if you see tremulousness, then it could be because of valproate or valproic acid. Next. Then again, as I said, look for gum hypertrophy. If the patient is on dilantin, they will develop this kind of gum hypertrophy. If it is too much, then you have to stop the medication. Look for head injuries or other injuries, burns on the body. You can see the patient here, who sustained abdominal burns while she was cooking and had a seizure. Next. And then once you got all this data, you need to really analyze as to what you're going to do for, what would be the next step. So what are the key questions that you are dealing with? So first thing, if patient comes with an episode of abnormal consciousness or loss of consciousness, the key question is it a seizure? So that, Dr. Roop discussed how do you differentiate between seizure and a non-seizure event like syncope or psychogenic event or for that matter, panic attack. Then the next question is the single seizure or the patient has epilepsy, meaning that they are having recurrent seizure, in which case you will have to put the patient on anti-epileptic medications, which the patient needs to take for long duration. Then the next question is, why is the patient develop a seizure or epilepsy? So is there anything that is quick, that can be quickly fixed? So for example, hypoglycemia, you can quickly fix hypoglycemia. Or is there something like a brain tumor or a stroke that is causing this? Then look for comorbidities, like does the patient have associated other conditions like hypertension, diabetes, or stroke? Or there are other complications like depression, burns, and injuries. And then there are social issues that one needs to be aware of. So for example, problems with occupation. So if there is someone who's a laborer, who's the only breadwinner in the family, if he develops seizures, then it puts the whole family at risk of poverty. So that is something that you need to ask and aggressively treat such patients. Marriage is an issue, a social issue among patients with epilepsy, and financial burden. And that's the advantage, because if they can come to primary health center, government's primary health center, then their medications, the cost of medications, which is about 60-70% of the cost of the entire treatment, can be offloaded, and they can be saved from poverty. So then you finalize a plan as to how you want to manage the patient. Next. So investigations. Next. So as Dr. Roop mentioned, the simplest thing that you would do would be, you can do blood glucose, you can do CBCs, and if possible, you can do serum sodium. In children, we try and get serum ionized calcium if at all possible. The other test you might do is LFT, KFT. And if the patient is having fevers in a rural area and it's endemic for malaria, then you'll do testing for malaria or dengue if you're in the city. And then if the patient is sick for a very long time, so if the patient comes for fevers for like 2 weeks and then abnormal sensorium and a seizure, then you're suspecting meningitis, TB, scrub typhus. And so then you will do appropriate investigation, but usually such patient would be referred to a secondary level of care. Next. And as Dr. Roop mentioned, that video, asking patients to get the video of the patient would be, very useful in diagnosis. Just by looking at the video, 90% of the patients can be diagnosed properly by doctors. Next. And what is the investigation? The brain imaging of, choice. Choice is MRI, because MRI, picks up even small lesions, which would be missed on CT scan. So if possible, the best investigation is MRI with contrast. If that is not available, the next best is MRI. If that is not available, the next best would be CT scan with contrast. And if even that is not available, then just get a CT scan to see if there is a large tumor or large midline shift. But remember, plain CT scan without contrast will miss out on lesions, right? So just keep that in mind. So the key question is, when do we need brain imaging urgently? As I said, you work in primary care setup where access to imaging may not be easy. So what are the settings or situations where brain imaging needs to be done urgently? So one is acute head trauma, so head injury, the patient is unconscious and had seizures. Then headaches or vomiting, which again suggests raised intracranial tension. Focal neurodeficit, which lasts for more than few hours, and patient continues to remain unconscious after seizures, then you have to look into the brain and see what is happening. Or there is a history of cancer. So for example, there is a patient with history of breast cancer. She comes with new onset seizures. You always have to suspect metastasis to the brain. So always keep that in mind. So these are the settings where you will need immediate brain imaging. If not, then you can wait. So next. So what are the setups where you can have a few weeks or a month before you get brain imaging? So if there is an adult patient or a child with no past medical history, presenting with new onset seizure without neurodeficit or signs of raised intracranial tension, in such patients you have time to get brain imaging. you start medications first and then get brain imaging. Imaging can wait. So a patient with epilepsy who has few, seizures since childhood and he is presenting to you in adulthood, then there is no hurry to get this done. And patient with cognitive impairment suggestive of cerebral palsy. So for example, we used to call that mental retardation. So if a patient with mental retardation is, having seizures since childhood and presenting now, then you don't need to really, can immediately do brain imaging. It can wait. Next. And what are the things where you really don't need brain imaging? So if patient has febrile seizures, you have confirmed the diagnosis of febrile seizures, and it occurs only during, fever episodes, then there is no need for brain imaging. Seizures due to low glucose or low sodium or low calcium, again, don't need any brain imaging. Seizures which occur because of alcohol or drug or medication induced seizures really don't need, brain imaging. So there are certain medicines threshold. One of them is tramadol, which we use in managing pain. So if patient is on tramadol and gets seizure, it could be related to, the medication itself. Next. And then, there is another investigation, which is EEG. EEG is not needed most of the times. So, it's not urgently needed. It's only required in very few patients, right? And if EEG is abnormal, it is useful. If it is normal, then it is not useful in diagnosing epilepsy. So epilepsy, as I said, is a clinical diagnosis, and you have to go by clinical history and make the diagnosis. Next. So again, what I just said, that epilepsy is mainly a clinical diagnosis and investigations may be normal. Up to 40% of the patient, everything will be normal, including brain MRI, everything will be normal. But still the diagnosis is clinical and you have to treat the patient clinically. Next. So then next thing is, how would we manage a patient with epilepsy? So the key question is, do I start this patient on long-term anti-epileptic treatment? This is an important decision because once you start treatment, it is going to go for 2 years, 3 years, 4 years, 5 years. So it's a long-term treatment. So usually we start it when there are 2 unprovoked seizures, which are 24 hours apart, right? So if the patient had seizure today and no other provoking factor and had another seizure after 3 days, then that becomes epilepsy. So usually we start treatment for long-term treatment for seizures after 2 episodes only. But there are certain situations where we can start even after a single episode. So for example, if the patient gets MRI done and it shows some infection or it shows a tumor, then this patient is more likely than not is going to get recurrent episodes. So such a patient can be start on anti-epileptics even after a single episode. If the patient presented itself with status epilepticus, so the first episode itself was so bad that patient had status epilepticus, which is life-threatening and which is going to recur again, then you put patient on anti-epileptic medications. If there are prolonged focal seizures, or if the patient gets EEG done and it shows focal discharges, high-risk jobs. So for example, there is a laborer or there is a mason who works in building construction. So if the patient has 1 seizure, then you have to start the patient on, anti-seizure medication, because if he or she has another seizure, then there is a huge risk of fall and death. And there are certain epilepsy syndromes, and there is history of first-degree relatives having these seizures, then you might consider it. But the common ones are the ones on the top. Next. So what are the goals of therapy? When you want to treat, epilepsy, what do you want to achieve? So one thing is to make the patient seizure-free, because, each seizure, there is risk of having serious injuries. So for example, if the patient is driving a 2-wheeler and suddenly has a seizure, then there is risk of accident. If the lady is cooking in a rural area and she gets seizure when she's cooking, then there is risk of burns. So the next is, you also want to improve quality of life. And in rural area, I commonly see patients, getting a lot of injuries and burns and, miserable. They're not on anti-epileptic medications. You want to improve their quality of life. And we also want to identify other comorbidities, like, a lot of patients might have depression. Up to a third of patients with epilepsy have underlying depression. So you have to look for that and, treat it with antidepressants. Identify side effects of anti-epileptic medications early and then change the medication, and provide social, emotional support and counseling. This is also equally important. Just talking properly with the patient, counseling them is very important because they're looking for some social support. So what are the ways we treat epilepsy? So one is medicines, and the second is surgery. Dr. Roop briefly mentioned it, that some patients can, benefit, especially those who are needing 3-4 medicines to control seizures and they're still not controlled. A part of them might, respond to epilepsy surgery. This is just for your information. Your primary setup, we really don't deal with this. And then there are certain diets which can help, reduce seizures among children. But again, this is just park it somewhere in your brain that these are treatments of epilepsy. Next. So what are the, we have multiple types of anti-epileptic medications which are available. And this is really good thing because, 30, 40 years ago, there were not many anti-epileptic medications. Now we have plethora of anti-epileptic medications. And the neurologists, as neurologists, we tend to classify them as something called as narrow spectrum and something called as broad spectrum. And this is just park it in your brain. You may not need it on a daily basis. So there are certain medications which we commonly use, like phenobarbital, phenytoin, carbamazepine, are considered, narrow spectrum. These are usually, very useful for focal seizures, but may not be useful for, certain generalized seizures, right? While there are certain broad spectrum medications like valproic acid or levetiracetam, which are broad spectrum, which will work irrespective of the seizure type. So which can be used in all types of seizures. So next. So let's briefly consider their pharmacology, and you will have access to these slides. So you can, if you want to start patients or if you have queries, you can go back to these slides and understand what the dosage are. So commonly used medicines which are available at the level of PSC are phenytoin, which is also called dilantin, and carbamazepine. So we'll start with phenytoin. So phenytoin usually start with a dose of 200 milligrams at bedtime. The good thing about phenytoin is you can just give it once a day dose. And usual maintenance dose is 200 to 300 milligrams. Usually in Indian setup, we don't go about 300 milligrams because then you have more side effects. What are the side effects? So gum hyperplasia, so swelling on the gums we saw. Then ataxia, meaning that while walking, patient becomes unsteady. Sedation is side effect of all the anti-epileptic medications. Hirsutism means excessive hairs on face, and it could be a problem, especially in girls or young boys. There could be memory issues, bone loss in the form of osteomalacia, skin rash is a risk factor. And if you have to give IV phenytoin or dilantin, just be careful because if there is extravasation of IV, if the IV leaks out, then it causes local necrosis. So you have to be very careful about this. Then carbamazepine, again, the common side effects are sedation, dizziness, skin rash. So occasionally you can have Stevens-Johnson syndrome, which is a very serious skin disorder, which you can see with carbamazepine and phenytoin. And so if the patient who's on carbamazepine or phenytoin complains of skin rash, immediately ask the patient to stop the medication, come to you, and you have to change the medication. Don't continue it because then there is risk of having a larger Stevens-Johnson syndrome. Then phenobarbital is sort of an old style medication which is still available. And again, the side effects are pretty much similar: sedation, ataxia, depression. Memory problems is a big issue with phenobarbital. So if some of you are using phenobarbital, don't use it in elderly people. Next. Then the other common medicine that you will see is valproic acid. Valproic acid is an excellent anti-epileptic agent. The common side effects are, anorexia, weight gain is a huge issue. Nausea, vomiting, tremor is a side effect. Hair loss, polycystic ovarian syndrome is something that you need to keep in mind. And so we don't use valproate in young girls and those, women of childbearing age. And I'll come to this again. Thrombocytopenia, elevated serum ammonia are other risk factors. Other side effects of valproate. Levetiracetam is a relatively new agent. It's good because it doesn't have any liver toxicity or kidney toxicity, and it doesn't have a lot of drug-drug interactions. So this is a great medicine if you have it in PSC, which I doubt. But if one medicine, if you really, is easily available, is levetiracetam, which can, yeah. So at district hospital, if you are practicing, you try and use levetiracetam. Some rare side effects with it is, aggression or rage or psychosis in patients. So that is something that you have to, be watchful about. Next. And these are liquid. So if you are going to see children, then these are the suspensions that are available: tablets, starting dose, maximum dose, and how many divided doses you need to use. Just remember one or two anti-epileptic agents and use those. Don't try and remember too many anti-epileptic medications. And if for one anti-epileptic medication, remember pediatric dose and adult dose because you're going to see children at PSCs as well. Next. So now let's try and switch gears. And we have a case scenario here. Rajesh is a 35-year-old laborer who was diagnosed with epilepsy 6 months ago. He's taking carbamazepine 200 milligrams twice daily regularly. Today he's brought to the PSC because he had a seizure. He denies missing any dose of medicine. So what will you do? So you can put it in chat box, or if you want to unmute and speak, please do so.
You can unmute and speak. Otherwise, you can put in chat box.
So patient is a 35-year-old laborer with epilepsy who is receiving carbamazepine 200 milligrams twice daily, and he now has a seizure, and he reports that he has not missed any medications. So what will you do? Excellent. So Dr. Anjali has responded, increase the dose. So please do remember that, we usually start at low doses and we increase the dose. And in rural area, patients start thinking that this medicine is bad. So they will, ask you to change the medicine. So you have to counsel them that, you're going to start a medicine at a lower dose and gradually increase the dose. So it doesn't mean that patient had seizure while on that medication, doesn't mean that that medication is bad. So that counseling needs to be done. Very nice. Next. So what are the strategies for epilepsy control? So the usual way we start is, start low and go slow. So start at a lower dose and gradually build the dose every 2 to 4 weeks. Because you have to see, what dosage the patient tolerates the medication. And then gradually titrate to the maximum tolerated dose before adding or switching to another anti-epileptic drug. So always start with one medication, go to the maximum dose, then add if needed. And always remember that dose of anti-epileptic medications may need to be increased if seizures are not well controlled at the current dose. So many times, I've seen doctors adding another anti-epileptic agent before going to the max dose of the, the agent that they are using. The good thing, as Dr. Roop also mentioned, that maximum seizures or epilepsy in patients with epilepsy, seizures can be controlled in 60 to 80% patients with just one drug. So, in patients with epilepsy in your communities, you can handle 60 to 80% of the patient because just one drug would be needed and they can be managed on that. Next. So how do you, manage patient with epilepsy? So first, make sure you are diagnosing it appropriately as epilepsy. So once you are diagnosed with epilepsy, start with anti-epileptic medication and start with any of the drug that is available with you, either carbamazepine, phenytoin, valproate, or levetiracetam. And start at a low dose, see if the seizures are controlled. If they're not controlled, increase the dose. And even after going to the maximum dose, if the patient continues to have seizure, then either add another anti-epileptic agent, or if you're not comfortable, refer a patient to the higher level of care. So this is a simple algorithm to manage patients with epilepsy. And as I said, 60 to 80% patient will be just managed on one medication, but you have to go to a good maximum tolerated dose. Next. There are certain anti-epileptic agents that we avoid in certain patient populations. So as I already discussed, valproate should be avoided among girls and women of childbearing age during pregnancy. Levetiracetam can increase, have some behavioral side effects. So someone is having ADHD or, behavioral disorders, or someone with depression or suicidal behavior, try and avoid this agent. Phenobarbital should be avoided among elderly because it causes memory loss. Carbamazepine and its cousin oxcarbazepine should be avoided in patients with hyponatremia. So in elderly patients, you have to be careful because they are at risk of hyponatremia. So how do we treat women among, women with epilepsy who plan to get pregnant? So first thing is seizures should be controlled well before the patient conceives. So, the usual counseling is needed. Among women whose epilepsy is well controlled 6 months prior to conception, their pregnancy outcomes are usually good. Carbamazepine and levetiracetam are relatively safe drugs among pregnant women. And as I said, that good seizure control needs to be maintained during pregnancy. And during pregnancy, there is volume retention, so fluid retention. So what will happen is your drug will be diluted in a higher volume of distribution. So the dose of certain anti-epileptic medications may need to be increased during pregnancy. At primary level, we don't have access to drug levels. So you can, if the patient has a seizure, you increase the dose. And usually with good seizure control, there are good pregnancy outcomes. So it is not like that people with epilepsy cannot conceive or have children. Next. And this we have already discussed. And the teratogenicity in a child is, related to number of medication the patient is receiving. So for example, if the patient is on one anti-epileptic, the risk of teratogenicity will be low, except for valproate. But if the patient is on 2 or 3 medicines, then the risk of teratogenicity will increase. Next. So how do we monitor treatment? Usually do complete blood count, SGPT, OT, and serum sodium at the beginning of the treatment, and afterwards you could monitor monthly or as needed. So usually you don't need a lot of laboratory monitoring, managing patients with epilepsy. If you have elderly patients who are on carbamazepine, then serum sodium needs to be monitored. Look for skin rashes with carbamazepine, oxcarbazepine, lamotrigine, and phenytoin as well. Because the skin rashes, if they're increasing, the patient can have Stevens-Johnson syndrome. So any patient with skin itching, skin rash, stop this offending medicine immediately. Try and change to other agent or refer patient to a higher center. Next. So the big question the patient will ask you is, how long do I need to take these anti-epileptic medication? The answer to that is, it needs to be taken for at least 2 years after the patient is seizure free on medication. So someone, has come with epilepsy, I started a medication and I gradually increased the dose and seizures got controlled after 3 months. So now that 3 months period becomes time 0. And after that, 2 years, the patient needs to take antiepileptics continuously. So if the patient is, seizure free for 2 years, some neurologists also prefer 3 years. So after 2 to 3 years, then you can start gradually decreasing the dose and stop. Right. Next. So again, as I said, that gradually reduce the dose and then stop. And if after patient was seizure free for 2 years on medicines, you went ahead and you stopped the medicine, and after 1 year the seizure recurs again, then the patient, that what is telling you is the brain is at risk of having seizures. So you have to continue it lifelong. Then these are things that Dr. Roop also mentioned. So management of seizures in casualty or emergency, or if the patient has seizure in front of you, what to do. So first and foremost is do not panic. The first reaction in the clinic would be everybody will be panicking, including sometimes nurses also panic. So don't panic. Turn the patient on one side. Keep the patient away from sharp objects to prevent injury. And remember that the seizure typically lasts about 1 minute, and maximum I said 2 minutes, and it will subside on its own. Right? So just turn on patient to one side. If there is a cushion available, put it under the head. Make the person safe. There is no injury. And time the seizure. Usually it stops after 1 minute. If it is not stopping, then it could be status epilepticus. Then you have to manage it accordingly. Right? And allow the person to recover. Next. So do not do these things during seizure. So don't put water or medicine in patient's mouth. Don't put spoon in mouth, because there's people in rural area believe that if you unclench the teeth, the seizure will stop. Usually by the time you are unclenching the teeth, the seizure automatically stops. So they feel that there is association between unclenching of teeth and seizure stopping. So never do this. There is risk of tooth fracture. Making patients smell footwear or onion, again common practice in rural area, it doesn't help. Or tying the patient or holding patient. Don't hold the patient, because there is so much energy with which the limb is shaking. Sometimes there is risk of fracture. So don't try and hold the patient when the patient is seizing. Just remove the sharp objects away from the patient and let the patient have seizure, and then it will stop on its own. Next. So then if patient comes to you who has already had seizure and seizure has stopped, so you don't need to do anything. If the patient continues to seize, then you can do benzodiazepines, and Dr. Roop mentioned the dosages that you could do, and I'm going to repeat them. And then patient seizure has stopped, you have to investigate like any seizure, first time seizure. So you do blood counts, try and get brain imaging. And if the patient is taking some seizure medication, then you just need to increase the dose of antiepileptic medication. Next. If the patient comes to you and having frequent seizures, so the patient has a seizure, then it stops for 5 minutes, patient is okay, and again has a seizure. Again, it goes on for a couple of minutes, and then again it stops, and again patient has seizures. So that is telling you that the patient is at risk of going into status epilepticus, because the seizures are occurring frequently. So you have to stop it. And the first treatment, if you are considering status epilepticus or frequent seizures, is give benzodiazepines, right? So you can give IV or intramuscular benzodiazepine, like diazepam you would have 5 to 10 milligrams in adults, or if you want to give in children, 0.2 milligrams per kilo, or lorazepam 2 to 4 milligrams. So usually in rural area, 2 milligram is sufficient. In urban area, when people are little, they have higher weights, then 4 milligram may be needed. And then load with anti-epileptic medication. So usually phenytoin, if you have injectable available, just put it in a drip, normal saline drip at a dose of 15 to 20 milligram, maximum 1500 milligrams, and give the drip over at least 30 minutes or 1 hour, so that the subsequent repeated seizures will be stopped. Remember that phenytoin and all these anti-epileptics medications take some time to act, while benzodiazepine immediately stops seizures, right? So immediate treatment should be benzodiazepines. Next. Now coming to the next case scenario. So we have a 34-year-old man with epilepsy who stopped his medicines 2 weeks ago. He's brought to the PSC today, and he's having continuous seizures for the last 1 hour. And when you examine him, he is having convulsions. His SpO2 is 88%. He's not responding to any verbal commands. What will you do? Again, please type your responses in the chat box, or if you can unmute yourself.
Can you repeat the question?
Yeah. So again, as I said, this is a 34-year-old man who's a known case of epilepsy, and for some reason he stopped medicines 2 weeks ago, and he is brought today to PSC and having continuous seizures for the last 1 hour. And when you examine him, he's having seizures. His SpO2 is 88% on room air. is not responding to any verbal commands. So what will you do? Very nice. So Dr. Amita has responded. She says IV diazepam and O2. Excellent. Dr. Ashwini has responded, give oxygen, but also, you have to stop these seizures. What is your diagnosis here? Please type, and thank you for participating in the discussion. What do you think is going on? What does this patient have? All right, I'll give you some time to think. Very nice. So Dr. Anjali mentioned that he's in status epilepticus. Dr. Kiran thinks this is breakthrough seizures. That's true, but the seizures are lasting for more than 1 hour. So this is status epilepticus. We'll come to the definition of status epilepticus. So very nice, excellent. Next. So it's a status epilepticus. And how do we define status epilepticus? A seizure that lasts longer than 5 minutes without patient regaining consciousness in between, right? So a seizure, typically it stops at 1 minute. Usually, most of the seizures are over by 2 minutes. But if it is lasting longer than 5 minutes, then we classify this as status epilepticus. And that recognition is important because it's a medical emergency with very high risk of mortality, right? So urgent treatment, even at PSC level, would be very important. And patient needs urgent referral to a higher center after the primary, treatment that many of you have suggested. Next. So oxygenation needs to be maintained during initial treatment because of constant generalized seizures, the patient is unable to breathe. So the patient will not be able to maintain oxygenation. And even during transportation, if the patient continues to have seizures, you need to give these treatments. The initial treatment, the first treatment is always intravenous benzodiazepine, right? So diazepam or lorazepam or midazolam, whatever you have to give it quickly to try and stop the seizure. And then load patient with anti-epileptic medications like phenytoin, valproic acid, or levetiracetam, injectable preparation. And if the seizures persist, the patient might need to be put on a ventilator. So you have to refer them at such a place where they can be put on a ventilator. Next. So what are the ways, you need to understand the principles of managing status epilepticus, and the timeline is very important. So 0 to 5 minutes, if the patient comes to you, usually it's a serious patient, you have to run your ABCs. So airway, breathing, circulation. So quickly check SpO2, check random blood sugar, do quick neuro exam for focal neurodeficit. And then next phase, 5 to 20 minutes, then stop seizures with benzodiazepines, IV, IM, rectal. So don't forget that sometimes, in children, you don't get IV access, then think of IM route or rectal route. Right? And then 20 to 40 minutes is where we load the patient with anti-epileptic medications. And this time is since the onset of seizures. So for example, the patient who came to us, the case scenario that we discussed, the seizure has been there for last 1 hour. So it's already, you have to quickly do all these 3 steps before you, start managing further. So ABC, put the patient on oxygen, check for blood glucose, give thiamine, if the sugar is low, give, dextrose. And then if seizure is not stopping, quickly give benzodiazepines. Right? Next. So what is 0 to 5 minute treatment? So as I said, airway, breathing, circulation, look for oxygenation, sugars, start oxygen with nasal cannula or mask. If the patient is really sick, then you have to intubate, and at PSC that may not be possible. So just put ambu bag and refer patient to the place where they can be intubated. Check finger stick random blood glucose quickly. If it is less than 60, give 100 milligram of thiamine followed by 50 ml of D50 or 100 ml of D25. And you have to give it very fast. In children, you have to give 2 ml per kg of D25, 25% dextrose. Obtain IV access, collect labs quickly, and then move on to the next step. And again, as I said, the first, after oxygenation, the first treatment is benzodiazepine. So what are the benzodiazepines that you can give? So if you have IV diazepam, which is widely available, give 5 to 10 milligrams stat dose, and it can be repeated once. If you have lorazepam acts faster, so you can give lorazepam 2 to 4 milligrams, or intramuscular midazolam can also be given. If you don't have any of these 3, then phenobarbital, if it is available, then you have to give phenobarbital. Or you can give diazepam, rectal diazepam, again, if it is available. If not, you can even give injectable diazepam rectally. And now there are intranasal and buccal preparations which are available, which are not available everywhere, but just for your knowledge that there are intranasal and buccal preparations. Next. And in the second phase, we load patient with anti-epileptic, and you have to give quite good dose of phenytoin, like 20 milligram per kilo. and avoid extravasation. So IV needs to be good, and it needs to be diluted in normal saline. Don't put it in 5% dextrose, it precipitates. So put it in normal saline and start a normal saline drip, usually 100 ml normal saline if it is available. Give it over 20 to 30 minutes. And if not, then you can also have other medicines, but these may not be available at the level of PS. Next. And even if the seizures don't stop even after these medications, then the patient is intubated and paralyzed using thiopental or midazolam drip. Next. Right. And status epilepticus with history of abnormal behavior in rural area considered rabies as a differential diagnosis, right? So ask for history of dog bite, because sometimes this can be missed. Next. Then coming to febrile seizures. So again, in primary care, you are going to see patients with febrile seizures. Remember the age group. It usually occurs between 6 months to 6 years. And you have to ask parents whether the child ever had seizures without having fevers, right? So they do not have seizures without fever. So always the fevers will, seizures will be with fevers. And the reason this is important is usually no long-term seizure medications are needed. Seizures usually subside when the child is 6 years old. So we have to counsel the parents, give paracetamol to reduce fevers, although there is no guarantee that even after paracetamol, the child may not have seizures. The child may still have seizures. And some, neurologists give clobazam, which is similar to diazepam. It's given for 4 to 5 days after the patient has febrile episode, right? But usually, routinely, this is not done. Then the other seizures you will come across in rural area is alcohol-related seizures. So these could be alcohol withdrawal seizure or alcohol-induced seizures. So these seizures occur only when patient takes alcohol or patient is, uses daily alcohol and then suddenly stops. That's when you are going to have seizures. Again, no long-term anti-epileptic treatment is necessary. You can give short treatment with benzodiazepine. So you can give diazepam, lorazepam, or clonazepam for 10 days to reduce the risk of having seizures. Next. So when to refer to a neurologist or specialist? Usually, seizures that are not controlled on maximum tolerated dose of 1 or 2 anti-epileptic medications, you should refer to a neurologist. Seizures with persistent neurodeficit, like weakness or numbness on one side, or seizures in a known patient with cancer, should be quickly referred to neurologist or specialist. Otherwise, you can manage 60 to 80% of the patient of epilepsy can be managed in primary care. Next. So what are the key counseling? And this is the last part of my talk. So what are the key issues of counseling? So medication compliance is extremely important. So do spend some time with patients. Tell them what is the importance of taking medicines regularly. In case of children, figure out who is going to give the dosage, especially in rural area where everybody is busy. Mothers, fathers, all are busy. So then you have to figure out who will give the medicines. Seizures while taking medicines. You need to tell patients that sometimes the patient might have seizures while taking medicines. And again, as I said, sometimes this is important because parents think that the medicine is not useful. So they will stop the medicine. They say that, oh, this doesn't work, because their expectation is all or none. So either the medicine will work or not work. So counsel them that you're starting at a low dose, you gradually increase the dose so that the patient doesn't develop toxicity. Can patients with epilepsy marry? Of course, they can marry and they can have children, just like individuals without epilepsy. But the seizure control needs to be ensured. Women with epilepsy who want to conceive, control seizures 6 months before conception, and they need to be put on folic acid before conceptions. And medication dose adjustment may be needed during pregnancy. As I said, the volume of distribution increases during pregnancy, so the dose of medication may need to be increased. Will the child with an epileptic parents also have epilepsy? Usually not. So there are some rare syndromes, epilepsy syndrome, where the child is at risk of having epilepsy, but otherwise, mostly they will not have, the child will not have epilepsy. Family education is important because, you have to tell them that it's not because of evil spirits, or it's due to an illness and there are treatment. And the key, the most difficult thing is for married women, especially, the lady who was having seizures before marriage, and now after marriage, if she has seizures again, then the in-laws want the lady to be returned back to their, parents. So this is a huge issue, and you have to really sort of counsel them. Schooling children with epilepsy, with proper control of seizures, children with epilepsy can attend school regularly and study unless they have some static encephalopathy or mental retardation. Here you will have to, counsel school teachers what to do in case, they have seizures, because what happens is the teachers get very scared that what happens if the child has seizure and something bad happens, then their job is at risk. So usually they don't want such children to come to schools, which is a huge loss for students. So you have to go and counsel. Sometimes, the teacher also need to be trained regarding what to do. Can patients with epilepsy work? Yes, with adequate seizure control, but they should not be engaged in high risk work, like they are going to work at height or their work involves being in water where there is risk of drowning. So this already mentioned risky jobs like construction work, work at heights. Then you have to ensure that their seizures are controlled well. But as a doctor, you have to tell them that this is not advisable. Driving in a patient with epilepsy, in India, the law says that the patient with epilepsy cannot drive. So this is just for your information. In rural area, nobody is going to listen to this, but it's your job to tell the patient that this is the law, and you need to know that this is the law. In other countries, patients are seizure free for 6 months; they are allowed to drive. Anxiety and depression is common among patients with epilepsy. You need to screen them, patients for anxiety and depression, and treat them with antidepressants. Epilepsy diary, if the child is having too many seizures, then it's good for them to maintain epilepsy diary so that you can monitor seizure control. Next. So coming to our last but one slide. So what are the take home messages? So epilepsy is common. As I said, there are 2 to 10 cases per 1,000 population. So again, as I said, in your PSC, you're going to have at least 40 children with epilepsy or 40 patients with epilepsy. Remember that diagnosis of epilepsy is clinical, so careful history taking is important. Most of the time, the examination is normal, and many of the times the brain imaging could also be normal. So the diagnosis is clinical. Brain imaging is needed to evaluate for intracranial lesions. And again, as I said, MRI brain is the best possible imaging, but if not available, CT with contrast. And if it is still not available, then CT can be seen for large lesions. The treatment start low and go slow. Start with anti-epileptic agent available at the PSC and gradually increase the dose. Adequately titrate the dose to achieve full seizure control as far as possible. Avoid valproate in girl, women of childbearing age and in pregnancy. Attempt to taper off anti-epileptic medications if the patient is seizure-free on medications for at least 2 years. Right? So always write down what was the last time the patient had seizures. So if the patient had seizures in the month of September, then you have to count 2 years from the month of September. And with adequate control of seizures, patient with epilepsy can live a life close to normalcy. So always, you have this enormous power in your hand that, with proper treatment, you can give them normal life. Counseling of patients and family members is utmost important to ensure medication compliance and providing social support. Next. And this is my last slide. So can we manage, seizure or epilepsy in primary care setting? The answer to that is yes. You can. What are the things that you can do in primary care setup? You can provide first aid after seizures. So if someone has seizures in the community and comes to them, then you can guide them appropriately. You can do some investigations, like you can do CBCs, you can do RBS. If in PSCs that are located in affluent area, you can refer them to get brain MRI or CT with contrast. You can diagnose patient with epilepsy. Again, as I said, it's a clinical diagnosis. You can assess whether the patient needs long-term treatment. If you have diagnosed the patient with epilepsy, then you can tell the patient that you will need long-term treatment. You can start treatment and you can manage with the single anti-epileptic that you have, you can manage 60 to 80% of the patient. And sometimes you may be able to handle 2 medicines. So, you can treat even more patients. Refer for investigations where needed. As I said, you can provide referrals for MRI or other brain imaging or testing. You can follow a patient to ensure medication compliance and looking for medication side effects. This you can do. You can counsel the patient. If the patient comes with status epilepticus, then you can provide initial oxygen, give IV benzodiazepine, and if you have injectable phenytoin, you can give the initial dose. And most importantly, your job is important because you can provide care close to him for patients, and which is going to save a lot of money for patients. So with that, I'm going to stop, and I'm going to take any questions that you have. Thank you for participating and putting your comments in the chat.
Yes. Thank you, sir, for wonderful session again. So, any questions on this? Okay, Dr. Arup Gurusani sir is also there for any kind of questions. You can ask any question and put it in the chat box. So, PPTs you will be getting on this portal itself. I'm going to upload the PPTs later on. Sir, there is one question from Dr. Ashwini that TB medicines, especially pulmonary TB and seizure disorders, please guide. So what can you say about it?
Right. Is Dr. Roop there? Yeah. Dr. Roop, do you want to address that question? So a patient is having TB and is on anti-TB treatment, and then which type of seizure medicines we should use? can you unmute?
Sir, can you unmute?
Okay, so Dr. Roop is having some issues. So again, I did not go into too much details, but there are certain medications which are enzyme inducers. So dilantin or carbamazepine or phenobarbital, these will reduce the level of anti-TB drugs. So usually you would want to avoid dose or be mindful of that, that it would be inducing these drugs. And valproic acid will reduce metabolism of these drugs. So it will increase blood levels of anti-TB treatment. So that's why we, usually prefer levetiracetam, which does not induce, or inhibit liver drug metabolism of the anti-TB treatment. So in a tertiary care setup, yeah, we will resort to using levetiracetam. But if not, then you will have to be mindful and, if possible, reduce the dose of these antiepileptics and try add another agent which does not induce the drug. Dr. Roop, would you like to add anything?
No, I think that's fine. What you said is correct.
Any other questions?
I think it's already 4:30.
Yeah. So again, we can go through the pre and post test question.
Yeah.
So thank you for your patience and participating. There is question regarding Alzheimer's. So if the patient has Alzheimer's and epilepsy, again you would treat it regularly. So now we'll go through these pre-test and post-test questions. So first was epilepsy is defined as any new onset seizure, recurrent seizures within 24 hours, two unprovoked seizures 24 hours apart, and none of the above. So can you type in, what response, or you can discuss it as well? Option C, very nice. So epilepsy is two seizures 24 hours apart. And then we'll move on to the next question. Can we scroll down?
Sir, before that, just one question is there in chat box.
Yeah.
That how to treat epilepsy in Alzheimer's patient?
Yeah. So, Dr. Roop, can you?
Yeah, so it's not really different from treating it even otherwise. You can use any of the drugs. And generally speaking, for an elderly person, I would prefer something, because they often tend to have other medications as well. I would often prefer levetiracetam, and they don't require a big dose. Maybe even 500 BD in an adult is enough. Is that okay? Yeah.
Yeah. So then we come to the next. Very nice. So thank you for typing in your responses. Then we go to the next question, that epilepsy can be caused by all except brain tumor, stroke, hypoxic brain injury, and hypoglycemia. Please type your responses.
Please type your responses so that.
Yeah, so some people have type D and some people have type B so far. So stroke can cause epilepsy. Hypoglycemia is a usually transient condition. It will produce seizures, but not epilepsy by itself. So the right answer here would be D. All the above can produce epilepsy. So brain tumor, stroke, hypoxic brain injury will produce brain damage, and they increase the risk of epilepsy. Then we move on to the next question. Dinesh is a 4-year-old boy, and for the last 2 days he had fevers. His family brings him to you as he had jerking of arms and legs and uprolling of eyes, and was unconscious for a few minutes this morning. He had similar problems once before when he had fevers. His temperature is 100 degree Fahrenheit and his clinical examination is normal. He's playful. What will you do? So get a CT scan, do lumbar puncture, counsel the patient, all of the above.
So because the C and D.
Yes. So we are seeing C's and D's. So the answer to this is most likely a febrile seizure. So you just have to counsel the parents, and that this is likely a febrile seizure and not a serious illness. So no further testing is needed. Good. Thanks for participating. Then we move on to the next one. So Miriam is a 12-year-old girl. She has sudden episode of unconsciousness at school when she was sitting in her class. She bit her tongue during the episode and fell off from the desk and had abrasion on her head. Which of the following features support the diagnosis of a seizure in a person with an episode of altered consciousness? So basically, in her history, what are the features that support that she has a seizure? So tongue bite, urinary incontinence, regaining consciousness gradually, and patient has no memory of the event, and E is all of the above. So I'm seeing a lot of E's. Yeah, all of the above. Very nice. Right. So all these features suggest that the patient, has high likelihood of having a seizure. We move on to the next question. Mansaram is a 45-year-old man with epilepsy who presents with 3 episodes of unconsciousness with uprolling of eyes, jerking of arms and legs, and tongue bite in the past 2 days. And in the second episode, he fell down unconscious while cooking and sustained burns on his right arm. He was seizure-free for 6 months prior to these episodes. He has epilepsy and is taking valproic acid 200 milligrams twice daily. What will you do? So ask whether he is taking medicines regularly. If he is taking regularly, increase the dose to 200 milligram in morning and 300 at bedtime. C, he may not be having true seizures. D, A and B, and A and C. So what is the right option? Yeah, a lot of you have answered as D. That's right. So, ask whether he is taking medicines regularly, confirm that, he is taking regularly, and then increase the dose. Next. So you are on a street and you see a man having seizures. What will you do? So this is something that all of us can, encounter, and we are not in a position of a doctor to do something in this. So A is try and hold his arms and legs to control seizures. B is turn the patient to one side. C, spray some water on his face. D, move sharp objects away from the patient. And E, all of the above. Then F is B and D. So turn the patient to one side and move sharp objects away. Yeah. So some people have said all. That's not true. So it's a tricky question. So it's just turn the patient to one side and move sharp objects away from the patient. Don't try and hold arms or legs of the patient or spray water on his or her face.
Sir, one request is there. Here our director, Dr. Ambedkar sir is here.
Right.
So I'm just requesting to speak about something.
Yeah. So
I'm just stopping the pretest for some time. And here, Dr. Nitin Ambedkar sir, Executive Director of SSSRC is here. So I'm just requesting sir to speak about this program a bit and addressing all participants and speakers. Sir, are you here? Yes, sir.
हॅलो, ऐकू येतंय?
Yes, sir.
ओके, थोडस लिंक बरोबर नाही, मला वाटतं. एनिवे मला ऐकू येत असेल असं अपेक्षा आहे. सर नमस्कार मंडळी, सगळेजण जे आज या वेबिनार साठी जॉईन झाले. आणि मी काय म्हणतो आता मधात आहोत आपण, त्यामुळे खूप ऑपॉर्च्युनिटी, पण आपले जे एक्सपर्ट्स आहेत जे तुम्हाला सांगतायत त्यांचं पण मी आमचे SHRC आणि आपल्या डिपार्टमेंट मार्फत स्वागत करतो या वेबिनार साठी. त्यांनी आपला वेळ दिला आणि ते आपल्याला काय म्हणतो मार्गदर्शन करत आहेत. सो टॉपिक आपण जे आता वेबिनारला सिलेक्ट करतोय ते आपल्याला डे टू डे याच्यामध्ये जे कामात येतात आणि ज्याला आपल्याला फील्ड लेवलला मॅनेज करण्याची आवश्यकता आहे, असे टॉपिक आपण युजली या वेबिनार मध्ये घेतो. त्याच्यापैकीच हा एक भाग आहे. आता यामध्ये जर आपण विचार केला तर आपल्याला जे सरांनी तुम्हाला सांगितलं असेल, ज्या हिशोबाने आपल्या भारतात किंवा जगातही आता या इपिलेप्सी किंवा तत्सम रिलेटेड गोष्टीच्या सो त्या हिशोबाने सगळे पेरिफेरल आपले जे इन्स्टिट्यूट आहे तिथले डॉक्टर्स असतील, फिजिशियन्स असतील, मेडिकल ऑफिसर्स असतील, या सगळ्यांना या बाबतीत अवेअरनेस आणि आपल्याला मॅनेजमेंट करण्यासाठी आपण सक्षम व्हावं किंवा रिओरिएंटेशन व्हावं, हा याच्या मागचा उद्देश होता. कारण प्रश्न मोठे आहेत, पेशंट्स आहेत, त्यांचं डायग्नोस्टिक्स वेळेवर न झाल्यामुळे किंवा कोणाला एपिलेप्सी म्हणावं, कोणाला वन टाइप सीझर म्हणावं, या सगळ्या गोष्टीच्या इश्यूज असल्यामुळे बरेचसे ट्रीटमेंट फॅसिलिटी आपल्याकडे होत नाही. म्हणजे जर एक स्टॅटिस्टिक जर बघितलं तर आपल्या भारतात जवळपास न्यूरोलॉजिस्ट जर आपण विचार केला तर फक्त 2000 आहेत असं काही स्टॅटिस्टिक्स सांगतात. परंतु त्या हिशोबाने प्रॉब्लेम्स आपले खूप मोठे आहेत. त्यामुळे या हेल्थ सर्व्हिसेसला सगळ्या स्तरापर्यंत इव्हन प्रायमरी केअर लेवल पर्यंत आपल्याला या गोष्टीचं अवेअरनेस आपल्या हेल्थ फॅकल्टीमध्ये त्याचा अवेअरनेस आणि त्या अनुषंगाने पुढे त्याच्या डायग्नोस्टिक आणि मॅनेजमेंट मध्ये त्याची कन्व्हर्शन होणं हे महत्वाचं आहे. त्या हिशोबाने मला वाटतं हा आजचा लेक्चर अतिशय महत्वाचं होतं. सरांनी ते घेतले पण आहे आणि तुमच्या या टू वे कम्युनिकेशन जे आहे त्याच्यामध्ये ते बऱ्याचशा गोष्टी आपल्याला शिकायलाही भेटतील. सो आता प्री टेस्ट कारण शेवटच्या याला आलोय त्यामुळे मी खूप म्हणत नाही, परंतु माझी सगळ्यांना विनंती राहणार आहे की जे आपण शिकलो त्याच्याप्रमाणेच आपल्या फील्ड लेवलला पण, कारण आता याच्यामध्ये वेबिनार मध्ये बरेच कमी लोक येतात, म्हणजे सगळेच मेडिकल ऑफिसर किंवा सगळेच लोक याच्यामध्ये जॉईन होतात असंही नाही. त्यामुळे तुम्ही ज्या ज्या ठिकाणी असाल तिथल्या सुद्धा लोकांशी माहिती शेअर करून डायग्नोस्टिक फॅसिलिटीज आपल्याकडे इम्प्रूव्ह होतील, क्लिनिकल मॅनेजमेंट इम्प्रूव्ह होईल, हे आपण सगळ्यांनी बघू. असंच एवढंच मला सांगायचं आहे. आणि पुन्हा मी काय म्हणतो आपल्या एक्सपर्टचं स्वागत करतो आमच्या पूर्ण डिपार्टमेंट बद्दल आणि त्यांना धन्यवाद देतो की त्यांनी वेळ काढून आपल्याला शिकवलं. सो आय रिक्वेस्ट डॉक्टर स्वप्नील, यू प्लीज कंटिन्यू. मी आहे बस.
Sir, you're on mute, sir. Dr. Swapnil, sir.
So I'm very thankful to Dr. Ambadekar sir to address all the participants, and I'm again requesting Dr. Kalkonde sir to continue the pre-test session so that everybody will get the answers of this pre-test. So we'll continue again back.
Yeah, so we discussed this, so what to do in case of and what not to do in case of acute seizure. So just turn the patient to one side and remove sharp objects. Then we move on to the next question.
Yeah, so one chat box, one request is there. So sir, please include CVA management in next CME. So yes, it is there in one webinar which we have planned. So we will try to keep it as soon as possible. Thank you. And recording may be available, but it will be taking some time.
So we move on to the seventh question. So Salma is a 25-year-old lady with epilepsy who is taking carbamazepine for past 1 year, and she's having well-controlled seizures. Over the last 2 days, she has developed
Sorry, participants, just some technical glitch happened. So I'm again repeating the question. That
So this is a 25-year-old lady with epilepsy and on carbamazepine, and she developed an itchy rash, which does not look like tinea. So what will you do? So please type your responses in the chat box now. We might have missed on some of those who have typed.
please type again.
Okay, so I think there's some delay here. So I'll move on. The right answer is stop carbamazepine. This could be a skin rash related to carbamazepine, and then change to another anti-epileptic agent. Next. So eighth is Dilip is a 45-year-old man. He drinks alcohol daily, and he's brought by his family because he has an episode of suggestive of seizures. He was under the influence of alcohol when this happened, and he had similar episode 6 months ago when he had consumed alcohol. What is the likely diagnosis and what will you do? So first is he's suffering from epilepsy, start long-term anti-epileptic medicines. Second is he had alcohol-induced seizures. Third is he had alcohol withdrawal seizures, and fourth is none of the above. So as you can see that this was, alcohol-induced seizures. So no long-term treatment is necessary. You can put the patient on benzodiazepines for 8 to 10 days and taper it off. Next. Which of the following sentences are true? So if the patient is having partial seizures, which Dr. Roop mentioned, this is old terminology, it's a focal seizure. The patient may not have complete loss of consciousness. B, febrile seizures usually do not need long-term treatment with anti-epileptic agents. C, in a majority of patients with epilepsy, seizures can be controlled on a single anti-epileptic medicine. D, the first drug of choice for status epilepticus is an injectable benzodiazepine like diazepam or lorazepam. E, diagnosis of epilepsy is mainly clinical. So which of these is right? All of the above, A and C, and B and D. So as you can see, in all of these statements are true. So the answer is F, all of the above. Next, this is the last question.
No, there are
Oh, there are more questions. Okay, so Janki is a 23-year-old lady with 6 months of pregnancy and brought to you with 3 episodes of loss of consciousness and jerking of arms and legs. These episodes occurred more than 24 hours apart. She reports having seizure as a child, but was seizure-free for some time. And her blood pressure and rest of the clinical examination is normal. You plan to start Janki on anti-epileptic therapy. Which of the following medicines you will avoid due to high risk of teratogenicity? So can you please type in your responses? So answers are phenytoin, carbamazepine, valproic acid, and phenobarbital. Yeah. So the answer is, valproic acid. And then we move